session won't be open tomorrow night. So fill up before 8 o'clock tomorrow night, and then come on down and celebrate what's been an amazing week. We've still got some incredible presenters to go first though, so let's introduce our first presenter who's come highly recommended to us. So yeah, a bit of pressure there for you, Brett. Let's hear it for Brett.
So thank you so much, Queenstown, and for what has been a fantastically exciting week. I think the energy that's been around this whole week has been fantastic. This has been my first EMS conference, hopefully not the last, and yeah, as I said, credit to you guys for just engendering such an amazing energy. So my name's Gerrard. I am an emergency specialist based in Auckland at Beaumont Hospital. I'm also a medical specialist, and I work for a company called First Assistance. So a bit of my talk tonight is going to be some of the trials and tribulations that we have experienced both through medical adventures with First Assistance. The last disclaimer I have to make is a number of years ago, I was employed for about a week as a Lothlorien wood elf in filming at Lord of the Rings. About 30 kilometres up the road, I spent some time wearing a long wig, some silver contact lenses, and generally sort of elfing around. So if anyone wants any recommendations for sort of elf activities or sort of places to go to avoid walks, just let me know. So what is repatriation medicine? So in a nutshell, it basically refers to the concept of getting someone who's ill or unwell overseas back to their home in the most optimal and sort of medically safe way. That's it in a nutshell. There's two main types of missions that we're involved with. The first is evacuation missions. So they can be basically taking someone from a relatively hazardous, dangerous climate and austere environment to somewhere where they can either be staged or sort of stopped out in the initial phases before getting them home. That can be anything from rescuing someone with acute mountain sickness off the top of a mountain, pulling someone off a jungle strip and flying by fixed wing to a sort of a larger hospital. I mean, I like to think of it as, you know, you're 2 o'clock in a bar with one of your mates who's just ordered another round of 15 tequilas. Rather than letting them carry on before she's going, you bump them back into an Uber and send the Uber on its way, and you hopefully get something safe at some stage of the night. The second type of mission that we're involved in is repatriation. So that's essentially once the patient is stabilised, you're then planning to get them home. Now that can be either via a commercial flight with a medical doctor or nurse or someone just to assist with that transitioning through a commercial flight, through airports, etc. Or it can be near ambulance, and we're often creating a mission for near ambulance. We go to someone with an ICU team or a medical team that's able to sort of facilitate the care and continue a high level of care all the way back home. So how does it all work? So what I'm going to just run you through a case. This is Peter. She's a 36-year-old mother of 2 from Melbourne. She's been on holiday with her family in Bali. On the night before she's due to fly out, she decides to pop down to the shops to grab some snacks for the kids and just some souvenirs to come home with. Unfortunately, on her way back to the hotel, she's hit from behind by a car and ends up on the road with multiple injuries, including a significant traumatic brain injury. She's whisked by an ambulance off to hospital, where she's immediately intubated and basically fully assessed for trauma in a pretty dramatic and stressful sort of environment. So as you can imagine, her family is extremely distraught, and the first thing they do is try to ring home, i.e. their insurer, to see what they can do to facilitate some help. Now, that's not the guy they rang. The people they ring is actually us. So we're an independent medical rescue company, so we work for a number of different insurers. And basically, when you take insurance out with them, we're the number on the bottom that you call an emergency. So we have a 24/7 group of case managers, nurses, and doctors that are able to engage with the family or the patient immediately on a stressful medical incident occurring. And that's certainly what happened in the case of Peter. So as you can imagine, her husband was extremely distraught, rang us. We were able to immediately contact the local medical team just to ascertain the nature of her She remained in ICU in Bali for about 2 weeks, had some really top-level care, and then once she was stable, she was extubated, obviously still not 100%, but we were able to organise the air ambulance to get her back to Melbourne. And the postscript of that story, she's actually doing very, very well. She's got almost a full cognitive function back again, and yeah, very, very lucky lady. So the world is a big, scary place. And it really wasn't long ago where we would head out, I was saying we, probably, in my younger days, and our parents certainly would head out into the world with little more than a scruffy, lonely planet, maybe some good pub stories, and that was about it. And you really didn't give a lot of thought to, what was around the corner. Nowadays, you can easily spend half a day Googling some brunch place that you're going to spend 20 minutes in halfway through your trip. And really the access to kind of that up-to-date knowledge is a real boon. But what people don't really seem to sort of realise, and quite naturally you don't think about it when you're off on an amazing holiday, is the medical systems or some of the medical care that potentially is going to be available or not available in some of the countries they visit. So I think the first thing that hits people when they do find themselves in a crisis is the realisation that not all medical systems are created equal. The concept of neurosurgery, for example, differs quite significantly between different cultures. And it's really not until you're within this whole system that you find out that there can be quite significant differences. This seems to be one that does catch people out, and I don't quite understand why. I think they automatically assume once they're in a sort of a hospital system, or they're surrounded by nurses and doctors, that they're all going to be speaking English fluently and chatting away to you in sort of fancy colloquial and medical English. That's clearly not the case, and this is often one of the major issues that people have and their families dealing with medical systems overseas. And I'll try not to do too much jazzing during this talk, I promise. The third and probably most important point is this concept that medicine is actually part of a bigger culture. And I think in Australia and New Zealand we do forget that because we're young cultures and young nations. But when you get to some of these countries that have this incredibly deep and colourful culture, medicine is just part of that. And I think sometimes we don't realise the impact of illness and health and wellness have in different cultures, and that's something we'll talk about a little more a bit later. So, when people travel, there is this expectation, I think, that they're setting the scene, they're setting the standard of care. When they get sick and they suddenly turn to their insurance companies, I think they believe that they're suddenly going to be thrust into this first class, first level of care, magnificent sort of facilities, and everything that people call. That left picture was me asking AI to tell me what a gym would look like on a Dreamliner. That's what they came up with. I suspect that would not make it through the health and safety programs. But unfortunately, the expectation is not what people come to realise. And clinics aren't quite as classy as they really thought. And most transport ambulances aren't also quite as classy as they expected. And it kind of, it sometimes makes me sort of shake my head because people go to these places in the middle of nowhere, these austere environments where there are perfect facilities, and then they get sick, and then they are. And so we're then faced with the challenge of working out the best way to get that person back to somewhere safe. So what I'd like to do is just pick a couple of random countries from around the world. I'm choosing these completely randomly. They're certainly not associated with amazing conferences or anything else. And what I want to do is just talk about some of the trials and tribulations that we may find if, for some reason, some of us end up listening to this. So let's start with Japan. Japan's incredibly well known for its in-depth culture, its language, its foods, and of course its swim schools. So I'd like to talk to you about a case of a 23-year-old chap who was skiing in Hokkaido with his girlfriend. Unfortunately, he took a nasty turn and smashed into a tree. As you may know, tree skiing in Japan is quite a thing, but clearly you want to be doing it properly. And he sustained a really nasty set of fractures to his femur. Now, we got a call from an extremely distraught girlfriend to say, this guy is in hospital, it's 6 o'clock at night, all the medical staff have left for the evening, he's been chartered Panadol, tomorrow die, they want to put them in a backslab plaster and put them on a commercial flame and send them home. And we're just going, right, okay, let's start with some painkillers. And it's very, very interesting when you start going into what is the issue with the Japanese and their process of, for example, charting stronger opiates or pain relief. Now, Japan has one of the most modern health systems in the world. It's got the third highest life expectancy. I think it's almost 85 years. Its doctors are exceptionally well trained. Their facilities are some of the most modern in the world. But there's, for several reasons, they have a very strong aversion to opiates and the use of opiates in medicine and subsequently sort of wider parts of pain management and care. When you go into this, you realise it actually stems back to the 18th century, where the British tea traders suddenly realised that they weren't able to transport as much tea from Western Asia, so from Ceylon, Sri Lanka, and India. Suddenly the Chinese worked out how to make tea. So they lost that trade, so instead they replaced tea with opium. So the opium flood through Asia was quite significant. So Japan witnessed places like China becoming extremely dependent on opium. There were huge opium wars that broke out, and they were able to sit back in isolation and realise this was not a great thing. So they shunned opium for quite a long way out. So you put that into the rest of the Japanese culture, and there's a lot of kind of terms and concepts that have passed through in Japanese culture from many, many centuries. And one of them is this concept of gamma. And this is the concept of enduring the seemingly unbearable pain with patience and dignity. So it's basically sitting there going, this is pain, I can deal with this, this makes me a stronger person because of it. And so actually tolerating pain is a quite strong part of their culture. There's also an aspect of the war survivors who realised that they had survived when colleagues and friends and family had died. So they felt this guilt, and so they will often refuse pain relief simply so that they can experience this gamma. So this is a really interesting part that you would not really sort of understand particularly unless you're really in a different part of the culture. The other big part in these smaller places is language. I'm sure you'll all recall an episode where Homer Simpson gets poisoned by fugu fish, and luckily on the back of his menu is a map to the nearest hospital so that you can go there and die. But in a lot of these smaller places, and this hospital in Hokkaido is a good example, English was not routinely spoken. And what would also happen is that the hierarchy, the way a hierarchy works in these smaller hospitals, once the surgeon makes a call on something like pain relief, no one can change that. Whether it's a junior doctor, a senior doctor, a nurse, or whatever, you're stuck with what this doctor has said, and that's what's going. So it was a pretty grim night for this guy, with not much more than paracetamol for pain relief. But luckily, in the morning, we were able to liaise and chat with the team. We had managed to get an operation. He got some good pain relief, and about a week and a half later, he was comfortable enough that he could get a business class lie flat seat with his new fracture repair back to Australia. So that didn't happen all right. Bali, what a beautiful place. Amazing scenery and of course amazing conferences. It's traditionally somewhere that has attracted a younger, sort of more exuberant crowd that tend to like doing sort of rather exciting, exuberant things. We already talked about scootering as a significant risk, but there's plenty of other sort of weird and wonderful activities that one gets sort of exposed to. I've got no idea what that final thing is. Everything in it scares me. Yeah, good luck with that. So clearly there's a lot of activities that people can sort of put themselves in line with that potentially could cause nasty trauma. Anyone want to spot diagnosis of what's going on there? Pneumothorax, well done, perfect. Anything else? So it's a nasty traumatic chest injury. The pneumothorax is significant. It's probably a little hemothorax at the bottom of that lung as well, and significant rib fractures. You can see some surgically semen tracking down the side there. Now, generally, those sort of injuries in New Zealand and Australia are actually treated quite conservatively, and we've been shying away a little bit more from traumatic chest tubes now. A lot of these things are just allowed to settle over time. In Bali, that's not the case. they have this procedure called rib clipping. Now to me, clipping is something that's done to hedges, toenails, and possibly pubic hair. But I will never want my ribs clipped. So basically what they do is a true open floor property. They'll go diving in, anything that looks slightly off, they'll snip it, and then titanium plate it back together. So you can imagine, the risks of infection, the risks of blood loss, the prolongation of pain and discomfort, and you've got a massive wound down the side. So this operation is pushing, certainly it lies and suggested on pretty much anyone with a rib fracture. So we often have to stand our ground and go, no, we don't agree with this procedure. It's not standard of care in Australia and New Zealand, and stand them down. And it's hard because often these surgeons will tell these patients that they will die if they don't get this rib clipping done. So you're often having these 2 or 3-way conversations with family, patients, and then surgeons as well. I won't be quite as cynical to say that it's something that gets charged a lot of money for, so there may be some ulterior motives in certain places, but generally the level of care in the private hospital is very, very good. And it's also nice to have a team looking after you from the other side to make sure this is all going in the right direction. The other thing about Bali is you're a tropical environment, so of course there's medical conditions, there's infective conditions. Rabies is a particularly fatal disease that we still see cases of around Asia, so people do die from it. It's spread primarily through the bites of infected animals, so commonly dogs, cats, bats, and monkeys. So if you are going up to Beaumont, okay, I'm just going to let you know about this guy. This is a monkey who has trained himself to take selfies. So he will take your camera and he will take these epic selfies while falling all over you, your family, and your loved ones. And sadly, we do get some significant scratches and monkey bites. Monkeys aren't actually the worst. The worst are dogs and cats. So if you're a professional cat handler, or you're one of these people who goes away on a holiday and just has to get up at 6 o'clock in the morning to run around the neighbourhood and get chased by rabid dogs, think about getting some preemptive vaccinations done. If you're caught and do get bitten, it can actually be quite frustrating to have to go through a number of vaccinations and or get some immunoglobulin as well. And it can actually quite disrupt your holiday plans. So just something to think about when you're up in Goodwood next time. So massive changes have actually occurred in the healthcare system in Thailand in the last 20 years. They have a universal public health system. They're actually ranked 5th in the world in terms of global health security, and that's kind of a marker of overall health system effectiveness. So they've really nailed the systems, especially in Bangkok and the bigger cities. Their private hospitals are world class. Their surgeons travel, they train overseas, so they have this incredibly sort of international insight into medicine. There's a lot of nice consistency. Most speak English, and it's not a bad place to get sick, put it this way. The private hospital system is, as I said, first world is absolutely fantastic. However, in Thailand there exists quite a diversity between places like Bangkok and the smaller sort of rural places or some of these islands. So this is a case of a 59-year-old male from Australia, who was on an island. He wasn't on a remote island, he was off the coast of the mainland. And he slipped on his balcony, fell backwards, and hurt his back. He was admitted to a local hospital, which actually had some reasonable facilities. It had a ward, it had an X-ray, it had a CT scan. So he had all those done, and effectively was diagnosed with musculoskeletal fracture. He was a biggish guy, so it was taking him a while to sort of mobilise again. But we were pretty happy with the care he got, the treatment he got. A nice report through in sort of English, but it was fine, so we were pretty happy. However, 1 week later, now there'd been a bit of a breakdown in communications, and the appeal in English wasn't sort of, there was one doctor there that had spoken good English, the rest of the staff knew nothing. So we had very little comms come through until the guy himself called. He goes, look, I'm just not getting any better. The pain is a little bit better, but I can't get out of bed. And he'd been using a bucket to go to the toilet for the last 5 days, and really had no idea from any of the staff what was going on. So this was a little bit of a concern. So any of you that are familiar with Jason Bourne will understand the concept of asset. What we have scattered around the world, particularly in Asia are local doctors or nurses that are very well trained to go into a hospital system or into a clinic or whatever, speak to the team that's looking after the patient, and get a bit more clinical information. So they're very adept at talking to the patient themselves, doing a full clinical assessment, and then reporting back to us. We don't have that many assassins at the moment, but we're certainly trying to keep the pulse of the ranks. So we got this guy back, and the clinical evaluation was a little more sensitive than before. So he had weakness in all his lower limb muscles, no reflexes, and as of the day before, he was now unable to brush his hair. And one of our nurses actually got this guy's diagnosis right at the moment. Yeah, possibly. We were thinking that as well. He had a normal CT, there was no major disruption to it, but yeah, a delay obviously was required. Absolutely. Guillain-Barré. So that's what he ended up getting. So Guillain-Barré is a progressive neurological disorder, not associated with his trauma at all, that usually progresses up through the body, initially affecting the lower limbs, then affecting the arms, but can affect the full muscular system of the body. So these people can go into respiratory failure, they can get major autonomic instability, require intubation, and end up in ICU. And that's exactly what happened with this guy. Within 2 days of getting back to Bangkok, he was diagnosed, intubated in ICU for about 15 days, tubed in ICU before his state enough again that we could air ambulance from home. So it is sometimes, you'll be playing a lot of guessing game, and yeah, as I said, the nurse was just nailing it. And soon got out and some straight away, we were able to make it whack. Morocco, anyone been to Morocco? Might quiz you about it later on. I haven't been there, it's supposed to be a stunning place. Not sure about the healthcare there. I do now. So this was a 56-year-old guy. 50s are definitely not the age to snipe rally. He had a sudden onset of chest pain radiating through to his back while he was out on the camp safari. So he was about 3 hours from Casablanca, and by all accounts, an extremely bumpy, extremely uncomfortable trip back. He was admitted to hospital there, where he was diagnosed with that. So that's an aortic dissection. Now, his aortic dissection was involving the arch. I won't go into debate and classification, but essentially it was involving the arch and looking like it was starting to move both ways. So becoming an A and also becoming a B. So the A's are the ones that generally potential life threats and require urgent, emergent surgical intervention. The B's are ones that are often treated medically with antihypertensives and observation, though again that's changing as well with liver surgery. So we were in a little bit of a conundrum. So we got all this report through, and we thought, okay, there's 2 options. One, we allow them to undergo acute surgery in Casablanca, and we Googled it, and yes, they did have a cardiothoracic surgeon, but we think he had 2. But it was like the names were really similar, so we weren't sure it was like the same guy with a spelling mistake also. But there was definitely one. We definitely knew there was at least one cardiothoracic surgeon in Casablanca. So that was good. Or we organised an urgent air ambulance and fly him back to London, where we would be comfortable with his care. So just a little straw poll. Who would like to have surgery done in Casablanca? Right. Well, this is the question, right? This is we said he was stable, hemodynamically he was stable, but we had no idea how this was going to progress. Sorry. Yeah, so we discussed that, and you're right, you could jump across. By the time we got the logistics all organised, we had what we call centres of excellence dotted around. Another one would be Berlin, which would probably be equidistant. By the time we'd done that, London was just the kind of thing. And I think the other was he had family in London or something, was another mitigating factor that we were looking at London. But yeah, you're right, you've got options. So, air ambulance to London. So we thought about this, and it was an interesting time to kind of reflect on some of the stresses associated with an urgent air ambulance mission. So hypoxia. Hypoxia, most commercial planes are between 8,000 feet and the Dreamliner 6,000 feet. So there is always going to be an element of hypoxia. Now, Air ambulances can be pressurised to sea level. That takes a significant amount of petrol, but it can be done. But certainly in a normal plane, you are going to be exposed to a degree of hypoxia. And if you've got some critically diffused tissue, like heart and brain, then that certainly could be an issue. Gravitational forces. So they tend to occur most significantly on takeoff or landing. So it's a significant shearing force that potentially has stress blood vessels can put under. So that was another thing we were sort of thinking about. Barometric changes, so any gas that's in a gas-filled body space is potentially going to undergo change. It's either going to increase as you go up, reduce your altitude. Probably not something majorly concerning for him, but it's certainly something you think about in things like pneumothoraces or occult trauma. Thermal changes don't tend to be an issue, they tend to be more associated with pre-hospital concerns or long-haul flights. Vibration, again, same as the gravitational. If you've got a constantly vibrating environment, if you've got a big pot sitting in your aorta, is that a good thing? Don't know. And other things like noise, that can just add stress. Blood pressure humidity and noise. Noise can be a stressful thing, may potentially cause blood pressure changes subtly. And fatigue, I mean, flying is tiring. It would only have been about a 3.5-hour flight, but certainly all the logistics involved with that. So with this guy, we ended up stabilising him in Casablanca. There were multiple CTs, and actually the section fracture worsened. His blood pressure was incredibly well managed, so we had a little bit of time. And then after about 2 days, everything was stable enough that they were going to discuss whether he could remove a stent on this guy, and we're able to transfer him up to London with his family. So he did all right, which is great. So what I just thought I'd do to finish off, I'm doing okay. I just want to go through a few kind of travel health top tips. I suspect all of us here are travellers of some description, and I just wanted to go through some of the little niggles that can sometimes occur when you take out insurance with whoever it is that you take out. So the first thing is this whole concept of pre-existing illness, and this can really bite people. If you've had an illness or you've been investigated for something, especially if it's in a relatively short time period before you travel, it's best just to declare it. If an insurance company finds any connection between the point of policy inception when you took it out and an illness, they could potentially declare that as being pre-existing and not cover you. If you recover from an illness, that's fine, but you want to check the policy fine print to see if those things are all okay. And as I said, it might be something as benign as you went to see your doctor 6 weeks ago with a little bit of back pain, and then you're over there and you go into massive spasm or you just collapse or something. They can potentially go back through the doctor's notes and identify that as pre-existing. Most policies will have rules against drug and alcohol intoxication. Now, it doesn't mean you can't go out to dinner and have a glass of wine. That's absolutely fine. Most recreational drugs are banned, and they will null and void your insurance. This is the Awakenings Festival in Amsterdam. But really do it, I haven't. But apparently pretty punchy festival. We had a 26-year-old Kiwi guy who attended this festival with a friend. After he arrived, he suddenly fell backwards and whacked his head. Got back up, he was fine, carried on dancing, and then a few minutes later went down again. So he had a double concussion hit to the back of his head. This time he didn't get up. So his friend got into an ambulance tent, and all over the ambulance notes are written, 26-year-old has taken cocaine and ketamine and has collapsed with a head injury. And it's written all over his notes. So they call an ambulance, he's GCS or something like that. He's pretty unconscious. They urgently transfer him to an Amsterdam trauma unit where he's scanned. He's got a massive intracerebral lead. He undergoes urgent neurosurgery that night. They bolt in, they drag it all out. His family flies out from New Zealand. But all the way through, it's got written, fell over secondary to ketamine, cocaine, drug use at festival, And he woke up, and they kind of explained what happened. The insurance company already said, we're not covering this drug use. He goes, I didn't take drugs. And his friend said, yeah, he was taking drugs. They go, but it says through here, and the family bank had, they said, and did you do any drug tests? And the hospital went, no. So he's covered, completely covered. So he was the only one who knows to this day whether he did or not. But because that would have been hundreds of thousands of dollars. Not a nice fancy trip at all. The third one is really just make sure you're covered for what you're doing. And a lot now, so Gerrard is a cruise package in most insurance companies. So one cover is like across the big ones, like a cruise package that you just have to buy if you go on a cruise boat, because the stuff actually cruise boats. And other things like skiing, there's often skiing that kind of makes sense. But the one that actually tricks people is a lot of them have for climbing. So say you're doing, you're going out for the jar or whatever, there's a limit to where you're allowed to climb to. Over some, about 2,500 metres. If you go over that, the risk of adversity is higher, and you have to stay at home going above 2,500 metres. And obviously just pay a little more for premium. Diving, all those other sort of things. Just think about what you're doing when you go away here on the trip and make sure you're covered for it. So it is a pretty scary world out there, but I hope that you all kind of continue to sort of get out there and adventure and throw yourself in these environments where no one speaks the language. You're off the beaten track. You're out there sort of experimenting and living life. And I think, I think these guys have done a fantastic job in taking us away to weird monthly places. But there's a lot more out there, and hopefully we'll get out and adventure and enjoy it. Thank you very much.
Thank you, Brett. Does anyone have any burning questions I'd like to ask Brett? Yeah, we've got time for one. Thanks.
What's the most challenging country that you've actually visited?
Yeah. Because, I mean, the ones where you can't get information, and actually we've had a couple of cases in, I won't say the actual country, but in Eastern Europe, in the Eastern Bloc countries, where no one speaks English, they have their way of doing things, and they're almost insulted that you're kind of asking them what's going on. And it's really hard. There's been a few cases where the family have just gone, we don't know what's happening, no one speaks English, we don't get any medical reports, we're just going to take the patient out of here and go somewhere kind of west of here. So those are tricky, they really are. Don't get sick in America without insurance. It's just a frightening system, and the cost of things is just, next level.
Let's hear it one more time, Brett. Just to make sure we're not cutting anyone off today, what we might do is just grab 1 2-minute break, stretch the legs, grab a coffee, and then we'll get started very soon. So thank you very much, everyone. If during the session at all you do feel like stretching the legs, there's plenty of room at the back if you'd like to stand up or grab some more donuts or tea or coffee. We've got 3 presentations tonight, so for our second presenter, I'd like to welcome Erin to the stage. Thank you, Erin.
Hi everyone, I'm Erin. I'm a nurse practitioner. I'm from Western Australia, and I predominantly work for a locum agency, Nurse Practitioner Locum Solutions. I work remotely in remote clinics, regional hospitals, and from home through our virtual emergency department. So that's what I've been doing in the past year, and I've got just a couple of cases, not too many. And I just was hoping that we could all sort of be involved, some of them easy, some of them a bit harder, and just also want to hear probably from you guys if you guys have anything interesting to add, more importantly. Alright, so I'll get started. So, case 1, we've got an 18-month-year-old boy who presents to a more remote, but sort of rural hospital, emergency department. They're acutely short of breath, they've got increased work breathing, severe intercostal recession, tracheotomy. They're Aboriginal child, and they're brought in with an uncle who doesn't know the child too well, but realised that the child's obviously unwell, needing hospital, and uncle has brought the child in. The child is screaming, basically wants the mum, and the uncle said that mum is on its way, but in the meantime, he's not really responding, more getting frustrated with the child at this stage. Observation, so we've got a respiratory rate, as you can see there, 65, stats are alright, 96, heart rate 170, temps normal, that's all done at this stage. So we've sort of auscultated the chest, but it's a bit difficult. We've got a screaming 18-month-old jumping all over the place, but we can hear sort of a scattered wheezing in between cries. Obviously, the child's alert, crying, which is always a good sign at this stage, and fighting us off, which is also reassuring. So our initial priorities, just to buy us a bit of time as well to work out what's going on, was to keep the child calm. So because we acknowledged that uncle was getting a bit frustrated by the child, which is fair enough, nursing staff took over, walking, rocking, basically just trying to get the child to settle down a little bit. It was sort of hands off the child at this point in time because we knew the child was, stable in a way, and it just brought us a little bit of time to work out what we were going to do moving forward, and get some notes and things like that. So it took a little bit of time to get some notes, being a remote rural facility. It often takes a bit of time to get out paper notes, and we started to go through them. So I was able to access some computer notes, which is great. So we had some summaries of 4 previous emergency presentations. They were just discharge diagnosis, brief note bronchiolitis. One of those included an RFDS retrieval, which resulted also in ICU admission. In some of the episodes, it was noted that the child had been responsive to salbutamol, but it was sort of trial but not trial for too long, if that makes sense. It was fully immunised, and the child was born from 34 weeks, but not really needing anything after birth, not intubation or anything like that. So, I suppose for you guys, what do you guys think this child could have, and what's your list of differentials? Anyone that's brave? Yeah? Perfect. Anything else? Yeah? Yeah, we'll go into that in a tick. Yeah. Yeah, could be at this stage, yeah. Because we haven't listened to the chest, we really have not really The other one, I suppose, it could be, you know, has the child breathing something, put something in his mouth. We're not sure. There's no stridor, no croup symptoms, so it's not croup, but obviously you put everything on the table at this point. So, top differentials at this point is obviously bronchiolitis with that wheeze, but also so asthma type presentation as well. Yep, allergies a good one. Yep. Just to note, Uncle did tell me though, it was around a 6 to 8 hour duration of symptoms, so not that sudden onset, so that ruled that one out, but good thought. Alright, so just this is really brief, I'm not going to teach you what each one is, but basically bronchiolitis, just a few brief facts. It is inflammation of the large airways, often caused by a viral infection, and the treatment for it basically is it's supportive care. So it's oxygen, it's supporting hydration, it's supporting all of those sort of things just to make the child have enough energy to get through the illness so it passes. So yeah, there's a few other things there that we do for that. The rest of you guys already know that sort of stuff. Just a new sort of guideline, I suppose, a bit of a change, and probably the reason for this topic. So, is it preschool asthma, and does anyone know what preschool asthma is? Perfect. Amazing. Right, so preschool asthma is, yeah, you're right, asthma or wheeze in the 1 to 5 age group who present with recurrent, but it could be their first presentation, wheeze, cough, difficulty breathing or activity limitation, all of which respond, or some of which respond to Vexillin. So the diagnosis of preschool asthma, this is just as per new guidelines. It obviously is difficult to diagnose, and it's difficult to work out what's going on. I know going back a little while ago, bronchiolitis was always, if the child is under 2, always bronchiolitis. It can never be anything else. And we did use puffers for some period of years. Puffers were out. So the term viral induced wheeze is a term that we no longer use. It's no longer recommended in the guidelines. The term that we now have used to replace that is preschool asthma, just to confuse us all. It's basically just a rebranding. So back to our patient. Thankfully, Mum's arrived, child's more settled, nursing staff are now free to concentrate on doing some monitoring and getting some sort of baseline test done. So child is calm now, but as you can see, obs aren't as good. So respiratory rates increased, heart rate has increased, which is good. SATs were 92%. Listen to the chest, there's widespread wheeze with a prolonged expiratory phase. Can't hear any signs of crackles or septic processes going on. Obviously got equal air entry. I can't hear any obstructions or anything like that. So our work of breathing has now changed to moderate and more severe. And the child's doing that seesaw pattern breathing. And being a small little team, starting to get scared. And obviously the child's not dehydrated at all, was sucking on a bottle from time to time when it first arrived. So, because we were remote, well not my only reason, but the decision was, well, we may as well treat as preschool asthma rather than just sitting back and doing nothing and treating bronchiolitis and using some oxygen and things like that. So, I'll just go through the asthma severity. I'll do it briefly because you guys probably already know this. So we've got mild, moderate, severe, and life-threatening. So mild, see the features So back to our patient. For our team, as I said, we categorise as severe. We're a small team in a fairly remote location, so we're 16 hours by road. Not that any of our patients ever go by road, they're always by RFDS. And our GP needs us out of town, and it's just me and the nursing team there. So I really do not want to have to intubate at all. So in that setting, obviously, we're more likely to overtreat than undertreat, just because we know that transport delays can happen, as they were told of at this stage. But also, we want to stabilise before there's any retrieval, as much as we can. So it's a bit of boring stuff for you guys, it's guideline. So the treatment started. We started for severe, pathway, and the first, the last one, the guideline, will be on the slides. Another staff member was arranging RFDS retrieval, because that is probably the thing that is going to get us in people the most. It was winter. Often we knew that the storms, the weather was a bit dubious later in the afternoon. So we wanted to get our patient on that triage system as quickly as we possibly could, just in case they did need that ICU admission again. So we started off with the standard 6 cups of Ventolin, 4 of Activin, and we did that first therapy the first hour. Child didn't like nails at all. Child didn't like really us touching them at all. So mum, as another asthmatic child, she gave the, first through the spacer, and that worked quite well. We gave prednisolone, 2 milligrams per kilo, oral, and at that stage, while child was still unstable, we weren't getting IV access because we really just wanted to keep the child calm, and hopefully this Ventolin was going to work. So we wanted to buy some time. So it was basically hands off the child, but we were delivering that Ventolin. Child didn't like monitoring, we didn't push it. So thankfully, after the first hour, or getting close to that first hour, probably after the second burst, we saw a real change. So respiratory rate is 50, we've got SATs 96, but what I was probably most excited about was heart rate, despite the subnormal state, come down. That seesaw breathing had stopped. We were still getting some moderate sort of increased worker breathing, but that horrible pattern was gone, which was good. At that time, after that hour, we decided that we were ready to get some IV access. We needed a retrieval. We didn't really need it for anything else, but it's always good to have if you need it. And the child was ready and stabilised for that. So we decided after the IV access that we were going to give the IV magnesium. We thought this would further stabilise the child for transport. And I don't know which of the things in the protocol obviously stabilise the child, but the child over the next 3 to 4 hours dramatically improved. So we gave obviously initially the 1 to 2 hourly Ventolin, and you can see the odds there. Respiratory rates come right down, that's normal. What we were more excited about was the child was running around happy, not much increased worker breathing, still obviously that wheeze every so often, but a totally different picture, which was great. So we cancelled retrieval. Family was happy for them to be managed locally. We knew our GP anaesthetist was back soon if we needed them. And they were just admitted to the ward just for general asthma our guideline used to be no. This guideline is yes. If they've had multiple responses to Ventolin, multiple episodes that have been responsive to Ventolin, and they've had those periods of time where it keeps happening, even in underdose, then they should start the 50 microgram lixified dose that you normally start kids up on asthma. The plan for that is also that it is fairly, it needs to be monitored more carefully than what you would with your older kids. So is it working? Is it not working? If it is working and then it's not working, do they need stepping up? Or does it need taking away in a trial without it? So it can change with age and needs to be reviewed more regularly. Alright, so that's that one, guys. I've got one more case at a totally different age spectrum.
Sorry, can I ask
Now this one, yeah?
I'm just curious, so how do we tell the difference then between bronchiolitis and
It's hard, isn't
bronchial
it?
asthma? Is that a dead?
Yeah, it's really hard. It's a real grey area, so the gut, you can't. So if it's the first presentation, for me, I'd give it a go to see if you get that response to Ventolin or to prednisolone. And if you don't get the response, then you stop it and go, oh yeah, it's probably bronchiolitis. Yeah, that's sort of the conundrum. I think that's what it's sort of in. And I think that's why the guideline changes every few years. Yeah. So my next case, so as I said, I work locum, but I work, predominantly my work is virtual emergency at the moment. Has anyone Victorian paramedics? Has anyone seen me before? Yeah. Oh hey, I hope I was nice. I do predominantly night shift. So my cases that I get, sometimes they can be a bit tricky, and they're a lot like the next one. So here we go. Right, so it's an aged care facility and it's a acute behavioural disturbance. So we get quite a few of these. A lot of my night is this. So paramedics contacted the virtual service about an 89-year-old man residing in an aged care facility. The reason for the call for the paramedics to me was to see if he could avoid PD transfer, which is great if you can, in an attempt to see if he can be managed in the facility. He was a very new resident and he shared a room with his wife. He was experiencing an acute, severe, agitated state, and he was pretty aggressive. So his behaviours had been escalating gradually over the past 2 to 3 days. But as it is, the information was pretty scarce of what was happening in the last few days. Overnight, he had physically assaulted his wife. They shared a room. He had entered the room of another female resident and touched her on the breast, which wasn't good. Then the care staff had tried to, protect people, and they had one of them being punched by him, trying to protect, I think it was his wife, someone, from being injured. So we believed it was new and acute, but we weren't sure because no one knew anything. Police, paramedics, a registered nurse, and care staff were present. The resident was wandering now around the facility, frantically trying to find his wife, and he was swearing and throwing around lots of furniture. Many creative attempts have been used to encourage a resident to take oral lansoprazole, but none was successful. So his past medical history was obviously a lot longer than this, but these are the main ones. So he's got dementia, 2 types, ischemic heart disease, hypertension, and past CDA. There's some of his meds, just a few important ones. So just to note, he's not allergic to anything, he's not a blood donor, he's on imperial insulin as well. So obviously a lot of the guys' decision making in any case in aged care is what is the resident's goals of care. And do they have an advanced care directive? That's So this patient did not have any directives. We tried calling the next of kin, and paramedics had already tried for a long time to call next of kin, but no one's answering the phone. We've all left voice messages to say, give us a call. So, as a team, we need to make a triage of the situation. So the situation, history of events, so we've got a gradual-ish onset over a 2 or 3 day period, but we were told this wasn't his baseline. Is the aged care facility equipped to manage the situation? It wasn't. It was a medium, no high care, no dementia-specific ward, and I think the reason for that was because he wanted to share his life. What is the resident's baseline, and is there any explanations? Illnesses, injuries, or triggering factors? So, quick assessment. He's harmed himself, harmed others. Nursing home doesn't have too much capacity to manage this safely. No medications in stock. The RN in charge is not willing to take from any other resident. There's a strict policy. They're not happy to replace the script. Very rigid. And also the medication side effects. If we are doing anything, it's not a safe place as far as nursing care goes. Nurses can't safely monitor that in that environment. So, very careful documentation for us all. Risk to self, punched his wife, he's had another resident, he's currently throwing vases and all types of things around the place. He's sexually assaulted another resident. And he's got an unsteady gait. And he's walking around the facility unaided. He's at false risk to self. Police death safety, we documented that. Damaged furniture, he's refusing to olanzapine, which was the only thing we had to give at this stage, which is a shame. So the nursing home, to manage it safely, is the question. They don't have any single rooms left, so we can't isolate him getting away. There's no locked dementia-specific ward. Registered nurses 1 to 25 residents overnight. No care staff available, which is a special. We can't lock other residents' doors in the rooms, it's a restraint, so obviously we need, written consent for that, the other residents, so that's a no-go. We don't really have any decent beds in stock. Residents' baseline, as I said, you limited history. The only history we can get, because the nursing home said it was sort of a rushed admission, is the resident's wife who has dementia. And she's really embarrassed by what her husband's doing. And she's not sure why he's doing it, and he's never done it before. But we're not sure still. We looked at the drug chart to see if he's got any appearance sedation, to give us any clues, what his baseline is. There was nothing on the chart, but this can also mean nothing, could have been that just was missed. And we're still unable to contact family. So other considerations, so check comorbidities, so why is the resident like this, is one question we've got. So he's on insulin, is his sugars okay? At this point in time, we don't know, it's not safe to do so. Has he had a recent fall of blood thinner? Has he got a bleed happening? And is this just his response to that? He hasn't had the falls. Is it a medical event? He's got to have past CVA? Has he got some other, event happening like that? Medication changes, obviously the delirium, and also like things like hyponatremia and things like We don't have family consent to chemically restrain him, but we don't really need it in this case, because he's obviously acutely not well. But it's always nice to give the family the heads up what we're going to do with their relative. I would personally feel much better about doing and speaking to them first. He's obviously in immediate danger from harm, and the facility can't deal with it. So we've sort of gone through those already. The other thing to add to that is the other reason to take him away from the facility is he's in a medium care facility. He's probably not going to be able to go back to that facility if this is his baseline. So we need to sedate for ED transfer. Has anyone got any ideas about what they give? Anyone else like anything else? So obviously there's lots of different ways to sedate someone. I'm not that scientific, I just go on my own, to be honest. What I'm comfortable with, what I've got. But things in elderly residents that we need to think about obviously is their metabolism of that drug. So obviously that drug, whichever one you pick, is going to hang around for a bit longer than usual. So pick wisely and be ready. So for this case, we had some olanzapine that we could give IM. We had some Gerrard we could give IM, and we had midazolam that we could give IM. So what are people's thoughts? What would you go for? Thankfully we didn't get there to all three. So just a quick rundown, nothing too fancy here. Just olanzapine, the dosing in elderly patients is 2.5 to 5 milligrams IM. The onset of action is 15 to 30 minutes, but it can be really variable depending on what this resident, because I don't have much medical history, has wrong with them as far as their renal function. So yeah, it's a little bit longer acting than Gerrard, so only real change. Side effects pretty much the same. So you'll notice here the side, so one of the contraindications, and I think you see it in some of your paramedic manuals, is it will increase the Parkinson's and dementia symptoms. However, at this point in time, I think everything is going to do that. So lack of sleep, there's no way we're getting that apart into them. So I don't really think it's much of a side effect, to be fair in this case, that we need to consider. It's temporary. So Gerrard, which was pretty popular, which is great. So my starting dose usually is on an elderly patient is 5 milligrams IM. Depends obviously again what's wrong with them. But you can go to 2.5, but I would prefer to get 1 IM shot than 2, especially when you've got to hold someone down, the risk of needle stick. Now there is some literature that says that it can cause the QT prolongation. It's not really negligible. It's not something we really need to worry about too much in this situation. And obviously those other side effects are the same. So midazolam, dosing 2.5 to 5 milligrams IM. It's basically similar side effects as the other two. I just find personally for me, I don't know, I'm more comfortable using midazolam in an emergency setting, controlled environment. When I'm using it out, I just feel like the dosing window, especially for an older patient, it can be a bit too variable for me and I get scared. And that might just be me. Somebody might be more comfortable just going here and using that. So outpatient, thankfully, just in time, we got a call from next of kin and I updated the situation. They consented for me to he, was discharged, they had to find a new facility, and obviously his wife was moved as well. So that's that case. But has anyone got any good? I don't know. People are probably better at sedating people than me, but has anyone got any hot tips? What they've used, what they have used, what's gone bad? Anyone? Be brave. No? And there was a bit of chatter about ketamine. Has anyone actually used it in aged care? How'd it go? Did it work? Yeah, it works. I did a bit of reading on it, and the literature was mixed from what I could read. It said that it can go one way, well, ketamine's not that included, one way or the other. I know it's on the paramedic guide, it's down the bottom of towards the bottom of your list of what you use, depending on which state you're in. But it can cause an increase in symptoms, so just be aware of that. Especially if that's your end of the line drug to use. Alright, has anyone got any interesting cases, any problems with aged care, sedating, any reservations, bad cases, good cases? How are we for time? Yep, cool. Yep, all good. Alright, that's it, guys.
Thank you very much, Erin. If anyone would like to have a chat to Erin in a less, I guess, scary environment, I'm sure you can find a little here after the session. We're going to move on to our final presentation of the night. And just while I bring it up, let's have a nice big round of applause for David Beaumont, a leader from local who's joining us.
Hi everyone, lovely to see you. Hope you're having a good week. Time for me, conferences are time for me, aren't they? I look forward to being educated, invigorated when I go home, but also that sense of shared journey and belonging that comes from being with a group of like-minded people. And therefore the social component is actually just as important as the educational component. So it's all right, you can pay me later, right? It's a great model. It clearly is a great model. And lovely to see, even from photographs, that some of you have come with your families, which makes it an even more special time. Except that I used to enjoy going to conferences to get away from the family, but I don't tell my family that, especially not my wife. I run health and wellbeing programs, and the commonest feedback I get from those programs is I hadn't realized how little time I spend thinking about myself. Whatever else you do this week, spend some time thinking about yourself. If we're going to look at if we're going to focus on your health and well-being, we need to know what health is and what well-being is. I've actually spent the last 24 years of my career contemplating those questions. Those and two others. What is disease and what is healing? Now, I mean, obviously, as doctors, nurses, ambulance personnel, health professionals of all kinds, we already know this. Except maybe we don't. Maybe it isn't properly covered in our training. Maybe there are presumptions made about these really common words. Certainly it was not included in my training. Cognitive dissonance is that really uncomfortable feeling we get when we know something to be true, we have a worldview, we have a belief about health, the way that the world works, is someone challenges it. Someone says there is another way to see the world. Well, I'm actually going to do that today. And when you're in cognitive dissonance, you have three choices. The first is to go, oh my goodness, I hadn't seen it like that before. Of course he's right. The second is to say, what a load of bollocks. And even to get angry about it. And I've had doctors get very angry, particularly GPs, including in international conferences. The third way is actually to sit in that discomfort and just accept that it's uncomfortable, but approach it with curiosity. I don't know if you noticed, Brett's slides had little quotes along the side, particularly at the start. And one of the quotes said, "Blessed are the curious, for they shall have adventures." So I want you to treat this session as an adventure. And it's an adventure for you. So I am presenting this in a group session, but actually I am speaking to you. And if anything comes up in this session that makes you feel uncomfortable, that bring things up that cause you personal challenge, then admit it, tell someone straight away, and ask for help. So, I've got a couple of questions that I'm just going to leave hanging for now. And I want you to ask yourself, what is my greatest hope for my health? And what do I need to heal? Just let it sit there. Just leave it there, being curious. So let's start with, what is health? Okay, so I was doing a tutorial to a group of medical students recently, and I asked them that question. Small group, and one of them chimed up immediately, health is the absence of disease. Great answer, great answer. That's certainly the understanding that I got from my medical training. Nobody actually said that, but everything that my teaching was geared up towards was detecting disease, regarding that as being unhealthy, treating disease, and regarding that as being healthy. However, one of her colleagues said, no. Health, let me get this right, health is a state of complete physical, mental, and social being, and not merely the absence of disease or infirmity. Yes, the 1948 WHO definition that is still their definition today. What does that even mean? I remember being taught that going whoosh over my head. It actually doesn't mean anything. It has been criticised robustly, particularly for two reasons. So, firstly, health is not a state. You're not either in health or not health. Health is a dynamic process, particularly when you include physical, mental, and social well-being. It changes every day. In some ways, it changes multiple times a day, so it is not a state. But the other big criticism is this expression, a state of complete physical, mental, and social well-being. Okay, show of hands. Who in this room right now is in a state of complete physical, mental, and social well-being? We've got one maybe, one definite. That doesn't include me, okay? And if you have a disability of any kind, you're automatically excluded. So that definition cannot be correct. So, An international debate was stimulated in 2010 by Richard Smith, who was the editor of the British Medical Journal. And he actually led the development of an international symposium on the question, what is the definition of health? And it was interesting, they brought in people from all sorts of domains to actually debate this, and everybody agreed it is not a state, it is dynamic. A word that kept coming up was adapt, the ability to adapt, because obviously our health changes as we age, so it's how we adapt to that. And ultimately, interestingly, over the course of the week, they nearly got there but didn't quite. But one of the participants, very cleverly, went back to Holland, got her team together, and published the definition regardless. And Professor Machteld-Huber, said the definition of health is the ability to adapt and self-manage in the face of life's challenges. So that includes what happens as we get older. It actually includes what happens if we get an illness or a disease. You can have health with a disability, an illness or a disease. It depends how you adapt to it. Sir Michael Marmot went one stage further. Sir Michael Marmot, Professor of Global Public Health, and his Whitehall studies into Whitehall civil servants said, actually, there is one factor which cuts across everything else. Control is an independent determinant of health. The more control you have over your life, or rather the more you believe you have control of your life, the more healthy you are, and vice versa. And actually, the psychologists talk about self-efficacy. I believe I have control over my own life. My choices determine my future. The psychologists also call this internal locus of control, or sense of agency, or self-determination. So, I'm challenging your thinking now. I know I am. And I know how brave you are at asking questions. Answering questions when put on the spot. So, what is wellbeing? Let's have a stab at it. What is wellbeing?
Feeling well.
Sorry?
Feeling well.
Feeling well. Nice. I've never heard that one before. That's wonderful. Being safe. What an important word. Thank you. If I really put you on the spot and made every single one of you come up with a definition, you would all come up with a different one. And that's the same. Same with the organisations I work with. They often do define well-being as far as the organisation is concerned, but all of them are different. And you'll find out shortly why the organisations I work with are employers. But one of the things that is a really big focus at the moment is mental health. And when I talk to employers about wellbeing programs, they say, right, we want a mental health program. And I say, what do you mean by that? And they say, we want something that focuses on anxiety, depression, and suicidality. And there are some amazing programs in workplaces currently encouraging people to talk about how tough life is and suicidal thoughts. Now, it's a really important safety net that we need to put in place, but this is not well-being. This is not the ability to enjoy the passage of time, clearly. So we've kind of got, a lot of companies particularly have turned well-being on its head, and it's back to the absence of disease. if we actually sort out anxiety, depression, and suicidality, then surely that puts people into a place of well-being. It doesn't. So, here we go. Well-being, actually, the most succinct definition I've come across is the combination of feeling good and functioning well. Sorry, what was your definition again? It included well, didn't it?
Yeah.
Feeling well. Feeling well. Okay. But this is actually functioning well as well. This is how you actually engage with life. This is the ability to enjoy the passage of time. That's what. This isn't the full definition though, because every definition of well-being is a narrative definition. This is by Professor Felicia Hubbard, my favourite definition of well-being. I'm just going to read this because every single word counts. The combination of feeling good and functioning well, the experience of positive emotions such as happiness and contentment, as well as the development of one's potential, having some control over one's life, there's the control I've already talked about, having a sense of purpose, and experiencing positive relationships. Oh my goodness, if we could have that, even a percentage of time, that's not bad at all, is it? I want to talk about my greatest teacher. And I've learned a lot from my patients, but my greatest teacher has been life itself and my own experience. I loved general practice. In a village setting in rural England, north of England, there was one practice. We serviced the whole population. We never had locums. We did all of our own on call. When babies were born, we visited as soon as they went home. When Grandad died, we visited that night. And we made cups of tea, and this was proper family medicine. I stayed there from 1988 to 2000, when I was headhunted from general practice. I'm not sure anybody's ever said that before, but I was, because I had developed an interest in something else. There was something I loved more than general practice, and that was occupational health, or rather occupational medicine, because I then did my training to become an occupational medicine specialist, an occupational physician. Somehow, the British Medical Journal got hold of me, and a journalist interviewed me, and having done the transition from general practice into occupational medicine, and they did an article about this transition in the BMJ, and they're heading under who's like a young guy with all that hair. David doing his dream job. And that's how I saw it. That's me with an ICI chemical plant in the background, because my occupational health, my occupational medicine practice was all in workplaces. And it was indeed my dream job and remains my dream job. So I now consult to some of New Zealand's major employers, Fulton Hogan, Fonterra, Woolworths, Silverfern Farms, Fletcher Building. I'm actually National Occupational Physician to St John, which is obviously a connection with why I'm here today talking to you. And I was doing my dream job and realised that something had changed for me. And this is why I mentioned the 24 years, because in 2000, overnight I stopped prescribing. Occupational physicians don't prescribe. My focus stopped being about finding disease and treating it, and instead it was keeping people healthy and functioning well at work. And if people went off sick or an illness or an injury, my job was to rehabilitate them back into the workplace with multidisciplinary teams working with them to support them to recover function. Then, on the 4th of November 2003, everything changed. November in the UK, in the north of England, is not pretty. It was a grim day. I was driving home. It was only 5:30. It was pitch black, raining, the phone went. My wife said, "Will you come and get some fish and chips? The kids are hungry and we've got nothing in." So I called and got some fish and chips. It was a stressful day. I got home and Emma and Matt, 9 and 7, were sat at the table, knife and fork in hand, ready for their fish and chips. And I said, "I'm just going to go and sit down for a few minutes." And I went and sat in the lounge, and a couple of minutes later, Susan came in and she said, "You're all right? You don't look very well. Shall I call the doctor?" And I said, "No, call an ambulance, I'm having a heart attack." And I was. The age of 42, with no risk factors, and fortunately, no interventions were required. And I was put on the usual cocktail of drugs. I was kept in hospital for 9 days, with no interventions. I really think it was just the local cardiologist was just in awe of the fact he'd got a local GP in his unit, so I was looked after extremely well. So I took the tablets, and that's pretty much all I did. And 10 years later, 2013, here I am with my best mate in the world, Phil, on the beach in Russell, across the road from the Duke of Marlborough, playing chess with a couple of pints of beer. Nothing could be better. Well, there's a bit of a cuckoo going on there. I hadn't changed anything about my lifestyle in that time, and a little bit of middle age spread's okay, isn't it? That's a photograph of happiness and serenity. The only thing is that it belies the true situation, which is that I was struggling with life, I was unhappy, my marriage was failing, and shortly after that I saw my GP and he said, "You're depressed. Antidepressants, counselling, halve your work hours, or I'm reporting you to the medical council." And he was doing it for my own good, I knew, and I did everything he suggested I did. And inevitably, my marriage did fail. And I did experience the dark night of the soul. And in that bleak moment, I realized I had nothing to turn to. I had no belief system. I rejected the upbringing, the religious upbringing of my youth. I become what I called, which I happily called it, become a devout atheist. I believed in nothing whatsoever. What that meant was that there was no meaning and purpose to my life either. But actually, do you know what? How long do antidepressants take to take effect? 2 weeks to the day. I looked in the mirror and I just went, "Oh my goodness, the mists have cleared. What's happened?" Maybe it was placebo effect, I don't know, but the mist cleared, and I started out on a journey of self-exploration, and I started looking for meaning and purpose in my life. Oh, which is, by the way, why I'm here today, because this is the meaning and purpose in my life. That was the time when I realized that health is more than physical. Health is more than psychological. Health is more than emotional, or social, or relationships. And in fact, it's even more than spiritual. What brings meaning and purpose to life? It's actually all four. And this is the Mari model of health, Tiffany's father. And the fifth domain, phenomena, the land, the environment in which we live, and suddenly you have completeness. And this is when I realized that health isn't about the absence of disease. It's actually about the transition between health and well-being, and getting the most out of life, and actually engaging in life. And I captured all of this into a book that I called Positive Medicine, Disrupting the Future of Medical Practice. Positive medicine, because this is an abundance model of supporting patients to develop health, not a deficit model, not a negative model like the absence of health. Disrupting the future of medical practice, I'm sorry to say, is overtly my purpose. I'm a disruptor, but I'm a positive disruptor, which is why I'm here today. I'm proud to say that the book won the British Medical Association Medical Book Award in 2022. And I tell you this because the importance to me was that the judges were my peers. The judges were doctors. And this was the first time that I realized that my message was getting through. So let's just have a look at paradigms of health and disease. So the way we see health, and certainly the way I was trained, is to see that the human body is a well-oiled machine until it goes wrong. And then it becomes diseased. And when there's a disease, something isn't working properly. We need to find out what it is and treat it. And as doctors and healthcare professionals, we know what we need to do to diagnose and investigate and put things right. The only thing is that this thinking, this Newtonian thinking, is 4 centuries old. It relies on linear thinking, linear cause and effect. Whereas, actually, there is a view that says that the human body is a complex system of interconnected complex systems, all working in a state of control, balance, and harmony. In disease, the systems have lost that control, balance, and harmony. The thinking that leads to this is called systems thinking, which is non-linear. Everything interacts with everything else. Causes leads to effects, leads to causes, leads to effects. Who knew that the human body was so complicated? Systems thinking comes from systems science. Actually, do you know what? Can I just have a show of hands? Has anybody come across systems thinking and systems science? It comes out of chaos theory, complexity theory. Yeah, a handful of people. This is new thinking. It's not been around very long, or it's not been. I mean, it started being talked about in the 1980s, but it's only really come to the fore. So, systems thinking sees the human body as a complex system of interconnected complex systems on multiple levels, with the ability to adapt and self-organize. And this ability to adapt and self-organize is something shared by all complex systems, known as complex adaptive systems. So our body is a series of complex systems, starting all the way from our life, down to our body, down to our organs, down to what we call our systems, respiratory, cardiovascular, etc. Down to our cells, down to our organelles. And I pulled out mitochondria as being an important factor here, and I'll come back to that in a couple of minutes. What this says, what systems thinking says, is that in health, control, balance, and harmony is the body's natural state. We know this. We have a name for it, don't we? What do we call it? I'm hearing mutterings of homeostasis. This is homeostasis. It's really interesting. I looked back, and I was taught about homeostasis, but I was just taught homeostasis happens. Systems thinking explains why homeostasis happens. In fact, it predicts that homeostasis will have. So what is health? Health is homeostasis. Simple as that. What is disease? Disease is disrupted homeostasis. It's not just me saying this. Professor George Beaumont is a professor of physiology. Amazing paper, Homeostasis, the Unappreciated and Far Too Often Ignored Central Organising Principle of Physiology, says that disease is disrupted homeostasis, and to address disease, we have to re-establish, we have to restore homeostasis. Think of that in terms of hypertension, which is disturbed blood pressure homeostasis, type 2 diabetes, disturbed blood sugar homeostasis, autoimmune disease, disturbed immune homeostasis. So what is healing? Healing is restoring homeostasis. Simple as that. Here's a case study. I love clinical trials where N equals 4. I'm not big on evidence-based medicine because it averages everybody out. So this is a person who in 2013 was pretty unhealthy. Okay, it's me. It's me. In 2013, you saw my book, and I was really unhealthy. I made a lot of lifestyle choices and changes from that time. But in 2013, my HbA1c was 42, and my doctor said, we're going to have to monitor that. And we did. And you can see what it did over the next 10 years. And that was despite me losing weight, living a much healthier lifestyle, getting fitter, healthier, happier, and that HbA1c just crept up to 47. January 2023, I went to see my doctor, and my doctor said, we're going to have to monitor that. And I thought, what are we waiting for? And I realised he was waiting for the magic figure of 50. He wanted to say, okay, now you've got type 2 diabetes, now we can put you on metformin and start the whole treatment regime. That's what most GPs do with type 2 diabetes. I kicked myself for having allowed this to happen for 10 years. And I went to see Dr. Glenn Davis, who was actually voted GP of the Year in New Zealand 2022 for reversing type 2 diabetes in 150 of his patients in Toowoomba. And I went to see Glenn, and he said, what I need to explain to you is that your system is overwhelmed. Bottom line, you've got too much energy for your energy expenditure, and particularly you've got too much carbohydrate in your system. But don't worry about it, we can soon sort this out. We just need to put you on a therapeutic carbohydrate restriction diet, and you'll be fine. And in 3 weeks, I actually couldn't draw that sharp steeply enough to show that all happened in 3 weeks. In 6 months, my HbA1c was, what am I calling it? 34. And I lost more weight as a consequence, but the aim wasn't to lose weight. This was actually, he calls it reversing type 2 diabetes. It's actually healing type 2 diabetes. So disease is disrupted homeostasis. Healing is restoring homeostasis. Sam Hazeldine. That's a prompt for myself. Sam Hazeldine is coming to talk to you tomorrow. Sam's a really good friend of mine. I was talking Sam through this a few weeks ago, and he said, okay, I get this in chronic disease, but it doesn't work for acute disease. I mean, imagine a patient who comes into an ED with a heart attack. We're not trying to restore homeostasis. We are. We're trying to restore homeostasis then as well. So where does disease and healing happen? Well, again, this is stretching your imagination a little bit, but disease and healing happens in our mitochondria. And there is an amazing paper here by Hampton neurologist Dr. Matthew Phillips, where he reviews the evidence that says that dysfunctional mitochondria are at the root of most, if not all, chronic diseases. Cancer, diabetes, neurological diseases, neurodegenerative diseases like Alzheimer's, all have dysfunctional mitochondria. And he is working on actually reversing, healing in cases of Alzheimer's, motor neuron disease, even glioblastoma, and having amazing results. But actually, I've already talked to you about systems thinking. Where does disease and healing happen? It actually happens at every system level. From our life and our body and our organs right the way down to and including our mitochondria. So healing happens actually by restoring control, balance and harmony in our lives. Life homeostasis. Google that phrase. Nobody else has ever said that before. But it's true. This is what we need. We need to find life homeostasis, control, balance and harmony in our lives. We talk about life-work balance, but it's actually much bigger than life-work balance. It's control, balance and harmony in every area of our lives, in the 4 pillars of health: physical health, psychological, emotional, relationships and spiritual health. What brings meaning and purpose to life? I call this whole person health. Back to that question I put to you. What is your greatest hope for your health, and what do you need to heal? Let's pull all of this together into something that is direct relevance to you. Before we do that, I just need to tell you about positive medicine principles. We are where we are. There is no point regretting decisions we've made in the past to do with any of those 4 pillars. There is no point wishing we weren't as we are for any reason, because wishing isn't going to change the past. We just are where we are. No judgment. You must judge yourself for that. Really important that we never judge our patients. I make sure I tell my patients every time, you can tell me anything and I will not judge you. The answers are always within. I spent my 12 years in general practice telling patients what to do. Cut down your alcohol, stop smoking, lose some weight, get a better work-life balance, come back in a month's time and we'll check your blood pressure and see what's happened. Guess how effective that was? Correct. Not at all. The answers are always within. We know what we need to do every time. Positive choices for positive outcomes. If you make one small choice decision today, it must have a positive outcome. It's the law. So, multiple small changes, multiple positive choices leads to positive outcomes. And behaviour change is easy. Now that's a bigger conversation because we've actually been led to believe that behaviour change is hard. It's really hard to stop smoking, for instance. No, it's not. You read Alan Carswell, The Easy Way to Stop Smoking from 1985, and he says, if you believe that stopping smoking is hard, then it is. If you believe that stopping smoking is easy, then it is. He is credited with having stopped more than 50 million people around the world from smoking, gambling, drinking alcohol. He's got a whole series of books called The Easy Way Tour. Massive foundation. making massive impact on the world. How's your physical health? How's your physical health right now? Physical health is really easy to understand. It's the bit about health that we're actually trained in, and there is so much in the media about now. And we know that there are things that we can do to improve our health. What one thing are you going to do today, or tomorrow, or when you get home this weekend, that is going to positively impact on your life? I'll give you a clue. There are 3 prompt words that I use to actually just give you a bit of a habit. And they're eat, move, rest. Eat. What can you do as far as your nutrition is concerned? Move. Actually, if I was to pick only one of these, the one I would pick is move. We need to move more. Go for a walk every day. Go for a walk at lunchtime. Go for a walk with your partner, or your dog, or your children after work. And rest. Get adequate sleep. Don't burn yourself out by not having enough rest. How's your psychological health? How's your state of mind? Are your thoughts, on balance, more positive than negative? I'm definitely saying, not saying you shouldn't have negative thoughts. We all have negative thoughts. I believe that we have psychological health when the balance of our thoughts are more positive than negative, and when our minds are clear, functioning well, or at our cognitive best. What are you going to do? What one thing are you going to do to improve your psychological health? Today, tomorrow, this weekend. 3 prompt words: enjoy, learn, do. Do get enjoyment from life. A suggestion: find yourself a bit of space, 10 minutes, pen and paper, and write a list. Write a list of the things that bring you joy. Just call it my list of things that bring me joy. And when I first did this, I just got so excited that in 10 or 15 minutes I wrote about 50 things that bring me joy. Fill a page and a half, or a page and 2/3 of A4 of the things that bring me joy. And then pick something from that list and go, oh my goodness, why don't I do more of that? I love doing that. Why aren't I doing it? What brings you joy? Learn. Stimulate your minds. Watch educational YouTube videos. Watch documentaries. Do some extra study. And do you know when I came up with these 3 words, I thought, do. Why have I come up with do? And I realized that psychological health is an action. It's a doing word. You have to do things to improve your psychological health. If you're anxious and depressed, then there are things you can do to treat that, but they, as I said before, they don't bring you well-being. They don't bring you psychological health. What can you do? Make a plan to improve your psychological health. Emotional health, our relationships. We're actually starting to get into trickier territory here. It gets harder as we go along. How are your relationships? What about that sister you haven't spoken to for 10 years? When was the last time you called your mum? What's the relationship with your partner like? How often do you tell them that you love them? Actually, how often do you say, I love you, and they say, I love you too? That's so easy. Do you know what it means? Nothing. Well, no, not nothing, because it depends on the context. Another tip. Another 10 or 15 minutes, write another list. My list of things I love about you. Think about your partner. Think about why you love them, and just let it flow from you. And when you've got your list, when you go home this weekend, then share the list with them, give them the list. Or better still, read it to them. And then just stand back and wait for the reaction. Oh my goodness. So the three prompt words are love, accept, forgive. Bring love truly into your close relationships. Accept that people are as they are. There is the only person that you can change in a relationship is yourself. You can't change the other person. Unless you change and they change in reaction to that, that's okay, that's allowed. But along with that has to come forgiveness. And forgiveness is another very, very difficult concept. And for me, the most important thing about forgiveness is letting go of the past. That doesn't mean to say that what happened was correct, that they were in the right. What it does mean is that if you're hanging on to it, then it's harming you, probably more than it's harming them. Spiritual health, the most difficult of all, except it's not. It's not about religion, unless it is for you. The three key words, actually before we go to the three, for me spiritual health is all about connections and what brings meaning and purpose to life. Connections with self, our true self, others, nature and the land, the potential of something beyond us, some kind of organising force within the universe, call it what you like, just the potential. But the three keywords are connect, reflect, and care. And the connect is truly connecting with ourselves, and reflecting is giving ourselves time to do that reflecting, and the care bit isn't caring for other people. This is actually caring for ourselves and looking after what we need. That's all this combination is what brings true spiritual power. Those questions that I asked you are meant to be a message of hope. This is something that you can do something about. Behaviour change is easy. Positive choices for positive outcomes. They only need to be small actions, but they need to be conscious choices and they need to be acted on. I hope you have some ideas. I hope you've had some insights. Allow yourself time to get the insights over the next few hours and days. Allow yourself the possibility that you might get epiphanies. The epiphany that goes, oh my goodness, I've not even thought of that. Of course I need to do that. That aha moment when it hits you right in the guts, you get a gut feeling, or you get it in your chest and your heart opens and you know you've got to. Health is about all four pillars of health. If anything of this has stirred you and you want to reach out to me, then please do. I'm very accessible. I'm also very active on LinkedIn, so follow me on LinkedIn. Thank you so much for listening. I actually don't mind if you have no questions whatsoever, because I would rather that you go inwards and process and go, this was all for them.
Thank you very much, David. And at the risk of undoing all the amazing words that David just shared with us, all I'm going to say is thank you, have a great night, and we'll see you here tomorrow. Good job.